I'd like to introduce David Coyle. He's the chair of the NKF KPA support group. David will be talking about what the support group has to offer to KPA. So, David.
And thank you, Jim. Good morning, everybody. Let's go straight into it. Next slide, please. So, and one more click. So the KPA working group is made up of myself, Jim and Brian, our president and vice president from the exec side, Andrea, Pete, Donna, and Fiona Broomhead from the staff side. And we've spoken about the working group before, we've met before, but just to remind you of two of our key purposes. Firstly, is to facilitate increased dialogue between KPAs and between KPAs and the NKF, and the benefits of that are obvious. And secondly, to raise awareness of existing and new types of support available to KPAs. We do lots of things about patient issues and so forth, but perhaps we don't do as much as we should about operational type issues that KPAs face, particularly you KPA chairs. So that was the purpose. Next click. So what have we been doing since we last came together and chatted? So Fiona's role is contacting the KPAs to update where they're at and see if they need any support. And she's been doing absolutely sterling work, gradually working her way through the KPAs. And I would encourage chairpersons, when you get the call, take the opportunity to give a full update and ask questions. And Fiona will route those questions back into this working group, and we will help wherever we can. And a good example of this, and David, are you on the call, David Kerry? Yeah, I can see
yes,
you.
Yes,
Yeah. So the North Staffordshire and South Cheshire KPA has gone through a difficult time. They were close to closing and in need of support. And so in recent weeks, Fiona's been very active talking with David, and the group has been supportive and available to David around supporting David himself. We've looked at recruitment to increase the committee size and other advice as he needs it. So it's a very good example when we say we're here to support KPAs, particularly who may be struggling. This is a live example. And I just wanted to ask David, if you just say a couple of words as to how things have worked for you and whether you've, where you are now.
Yeah, certainly. At the end of January this year, we were of a position where everything seemed okay going forward with the committee getting back to itself after COVID. However, we had a resignation at the end of January of a major player in our committee. And since then, we've been trying to replace the secretary. We've been trying to get back in touch with our membership, which has been extremely difficult. And we sought support from the NKF to increase our numbers on our committee, which they've helped very, very well with by making an appeal through the membership for people in our area to come forward. We've had success with that. We've had three new members join our committee, which has been great. We had trouble with getting in touch with our membership. We weren't sure who they were because over the time of COVID, we've lost touch with them. And Fiona Broomhead particularly has really helped us with that. We've had help on the website, not only from Pete Revel, but also from the people who run it for us. And we're now in a position where we understand that there are a number of people who've joined us through that website, which we were unaware of. So our membership has shot up from not knowing how many there were to apparently almost over 100, which has been fantastic in a very short space of time. We're now seeking advice from Fiona again, which has been helpful and that is how we manage the GDPR of that membership and keep that list up to date and keep in touch with those people. So from those point of views, things have been excellent. And we're now getting back to an even keel, hopefully, when we can run successfully and serve our members.
Thank you very much, David. So just an example there. So just on the last slide, we've launched the KPA WhatsApp group. It launched this week. This WhatsApp group is a closed group for KPA chairs. I don't know if David Marshall's on the line, but I'd like to say thank you to David, who kicked off the first question on the WhatsApp group, which was about helping patients with energy costs in these tight times. And that developed into a really fascinating conversation across KPAs about helping patients in these difficult financial times. So I encourage you all to join. It's a fabulous, already it started to be a fabulous place for discussion. Okay, moving on quickly. So medium term, 2 issues, next click, or 2 topics rather. We've mentioned before, we want to set up regional KPA forums because there are certain issues that are specific to a region. And given our speakers today, the primary example will be the changes to the integrated care systems and the work of the Rstp that we're going to hear about that are happening on a regional level. We may often have 4 or 5 KPAs within one of these regions. So it's very important that we coordinate with each other and make sure our KPA voice representing patients locally is heard. So it's in the early stages of development, but we have volunteers from the executive to host various regions. So we hope to be in touch with you shortly about a kick-off meeting, because it'll be for each region to decide the format and frequency of their discussions. Next bit. KPA webinars. We've talked about this, hosted by the NKF, focusing on KPA management topics requested by you. The idea is that they are informal format. We'll bring in guest speakers and experiences from NKF staff, KPA chairs, to share best practice, followed by a Q&A session. So that's the kind of format. We'd like to get one up and running reasonably soon. Next slide. So what's in front of you here is a selection of topics. It can be added to, it can be changed, and we encourage you all to make suggestions on a topic you think will be worthy of a webinar. So, as I say, the idea is this is where we'd share experience, we bring expertise in. So it could be on recruitment, very topical for some people, and that might cover committee members, KPA members and volunteers. It could be on charity management, GDPR, bank account management, passwords, AGMs, etc. And very quickly, Donna, do you want to say a couple of words about the work you're doing? Perhaps not. Okay. So
yeah, we're setting up a toolkit with ideas of how to keep your KPAs, passwords, etc. safe. And we're also offering to keep your passwords, such for your bank or your website, on our database at the NKF. It's a secure database and it's GDPR compliant. So we are willing to do that, to keep them on each individual record, just so that just one person hasn't got everything for your KPA. So hopefully that'll be set up in the next week or so.
Thank you. So my request to everybody on the call today is if you could vote for the topic you think should be the first topic we cover in the chat, or alternatively send an email through to Donna, then we'll then have our first topic and we can move on and deliver it. Okay, that's it for me. Thank you. I hope I'm on time.
Thank you very much, David, and thank you for David Kirby as well for his input. I would now like to introduce you to Dr. Ahmed Ullah and Neil Ashman, who are going to tell us about the Renal Service Transformation Programme. So over to you.
Thanks, Jim. So I'm Neil Ashman. I'm the clinical lead for the Renal Services Transformation Programme. I've got Ahmed Salim Ullah with me,
Nitin Kohli with me as well, and we'll introduce ourselves as we get to our various slides. Just Donna, thanks very much for helping with all our slides, and thank you very much to the NKF. It's a real pleasure to talk to you as KPA chairs. I hope you know how much the work you do matters to all of us as clinicians, not just to you in representing the patients of the many renal units across England and Wales. I'm talking to you from rather sunny East London, and I'm hoping to go walking out in Essex later on. So I hope you're all having good weather and are looking forward to as nice a day as we've got down here. So the Renal Services Transformation Programme is one of a number of transformation programs that have been set up across many services, including cardiac, which is looking after people with heart failure and heart disease. Next slide, please. I'm not going to talk to this because it fundamentally, I think, describes an individual's pathway with kidney disease through life. This, to my mind, is the problem. It isn't always a problem. Sometimes things work really well around people, particularly when an extreme emergency tends to intervene. But for far too many individuals living with kidney disease, there's a long spell of uncertainty. There are bumps in the road that are often dramatic and life-changing. And then there are long spells, often facing down difficult treatments in difficult circumstances that make extraordinary demands of your lives, of people living with kidney disease's lives. And there is a sense, I think, that we haven't always been as good as we could be in the NHS as looking to the individual and providing care for you, that one person in the middle of many living with kidney disease. I'm not saying that's necessarily what Rstp is aiming itself at, but I'd like to believe it's no small part of what we want to do through this program. Next slide. This, to my mind, is a state of the nation and what's going on in kidney disease, particularly in England at the moment. So we know a lot of people have got chronic kidney disease. They may not know it though. And far too often people are living with CKD that they may know about, but are unaware of how quickly their disease is progressing, if it's progressing at all. Some are very anxious about living with CKD. Others are unaware that they're living with CKD until it's too late to do anything about it. I think there's a real problem about how we inform, how we diagnose, and how we support people in the early phases of CKD that we traditionally may not have paid the attention to that we need to. I think there's a real issue around what people living with kidney disease have on their plate beyond their kidneys: heart disease, diabetes. For many, it might be living with vascular disease. It might be living on a burden of medication that can be quite extraordinary sometimes, having had very difficult and complex disease early on in their lives. So I think that ability to look at beyond the kidney is something we don't always join up very well. And I know people in my area of England who have to travel to 7 different hospitals to get 7 different bundles of care around themselves, rather than being able to coordinate that in any one place. We know around 7,000 people start kidney replacement therapy in England every year. And my concern is far too many start underprepared and don't have wrapped around them what they need. And that might often be social input, it might be psychological care, it might be counseling. Far too many start not even aware that they have kidney disease. And there's still a significant number, perhaps as many as 1 in 4 or 1 in 3, who start dialysis without the awareness that they have kidney disease at all. I think the money around dialysis, how we pay for dialysis and transplantation, feels unnecessarily complex. We don't, for instance, invest at all in psychosocial health and well-being, in supporting people's mental health. I don't think we've got enough around transitioning children. There's definitely something about wrapping support for utilities bills, which I think you're going to be talking to. You know, home dialysis at the moment must be increasingly demanding as electrics go up. I don't think we've got that right. I don't think we support transport particularly well for those that need it. Nitin will talk to acute kidney injury, which is one of our prime areas to want to do work around. And then it seems to me that we are incredibly wasteful in the NHS in allowing acute kidney injury either in the community in primary care or in hospitals, which can often cause a step change in people's kidney function that can have lasting consequences for the rest of their lives. But there are other areas that we're not particularly good at. There's so much variation. How likely are you to get a transplant before you start dialysis? Can often depend on the center that you receive care on. And sometimes that can be always and months, many months before you would have otherwise started dialysis, to some actually starting dialysis before they're even offered transplantation. Home therapies, how likely are you to be offered PD or to be able to go home? And we're incredibly supportive of the NKF's drive to increase the uptake and increase the support around home therapies. But there's no doubt there's a lot of variation in that space that isn't explained by the variation in the people that are receiving care. How are we preventing and diagnosing CKD in primary care? This doesn't feel as though it's well done. We used to have testing for both GFR through a blood test and also urine testing for proteinuria within how GPs were awarded in their contracts. That went some years back. We think there's a real case for reintroducing that, particularly for people living with high blood pressure or diabetes, to try and prepare people much further in advance. And then finally, I think there are inequalities driven through this pathway, inequalities of what you're offered, depending on your postcode, inequalities that might relate to your age, about what you're offered, inequalities in ethnicity and how you're treated or diagnosed, inequalities in whether or not you have serious mental illness or not. There are so many things that we call variation that the UK Renal Registry, an absolutely brilliant organisation, has reported on regularly, but we don't seem to have done anything about over the last quarter of a century. Next slide, please.
So integrated care is coming.
And I think the Rstp is in part a response to the long-term plan, which was first released in 2015 and is now about to become a law through an act of parliament. And picking up on what David was saying earlier, my view is the KPAs are about to become exceptionally important instruments for guiding these integrated care systems. So it's not just at regions. So if we think there's 7 regions, London, Midlands, Southwest, Southeast, Northeast, Northwest, and the like, those have usually got populations of up to 10 million people. They're big. There'll be many, many renal units, many, many KPAs in those. But ICS levels, there'll often be fewer, and you may only have 1 KPA in an ICS. So there are 5 ICSs in London, and there's 7 KPAs. And each region will often have 4 or 5, perhaps 6 ICSs within them. And I'd like to believe that this is where the KPAs will increasingly have their impact. And I'd encourage the NKF to think in this fashion. The KPAs should be on every single renal network in these ICSs, acting as the patient and public voice to drive the change that you want to see, because we want to see it as well within the Rstp. So these integrated care systems will bring together populations of between 1 and 2 million. And the aim is to join up care, to actually join it up in a way that allows planning around an individual, that is able to focus on preventing ill health rather than waiting for someone to walk through an ED front door, that is able to support people as they come out of hospital to actually get better and to rehabilitate at home and in the community. There's a real drive around equity, a real desire to level up, but not level down, to make sure that everyone gets the opportunity that they need. And we're hoping that population-based budgets will allow this. We're absolutely clear that the renal budget as it stands is protected. So there's no question that we're going to see renal money that has traditionally been needed for vulnerable people living on dialysis will now move into another sector, for instance, underfunded primary care. We're pretty persuaded that these population-based budgets are the beginning, and they're certainly not an end, of how we might finally be able to wrap funding around an individual to look to all of your care needs. And then finally, there's something about wanting to look at a whole system of care. And I'd alluded to this, which is I don't think it's right that people have to go to 7 hospitals to receive 7 different widgets of care. I think we've got to start coordinating single stops. If you're coming to dialysis 156 times a year, why on earth can't you receive your diabetes care, your eye screening, maybe even have a well-being check on those days that you're on dialysis? I think we've been incredibly inflexible in what we expect of you, our patients. Next slide. I'm not proposing to talk to this. You don't need to see my ugly mug twice, once on a screen and once on a screen. But these are the sort of models of care that I'd hope we'd be able to see. Primary care is struggling. I don't know how easy you're finding it to get into your GPs at the moment, but GPs are finding it really difficult to offer the access that they did pre-pandemic. We have got to make ourselves as kidney clinicians, doctors and nurses, pharmacists and dietitians available to primary care to make sure that if a GP needs advice, he or she can seek it really quickly. And then we in turn can find those most at need and bring them up as quickly as we can. So my Monday afternoon clinic, I used to have about 6 minutes to see someone. I don't think that's enough time to have a quality consultation. And I'd urge you to time your next consultation with your kidney team. Tell them you're going to do this. But I think you'll often find that you end up getting 4 minutes and a blood pressure check. I don't think that's what we should be offering. I think we've got to say, how can we actually stop seeing those who are fundamentally well too often and start seeing everyone at least once or twice a year and give them the time to discuss their family, work, the bills, think about the tablets they're taking, what is working, what isn't, fatigue, depression, as well as blood pressure and kidney disease. And I think that richer consultation is what we need to be aiming for by freeing up time. I'll stop after this slide, but I hope I've made a case for saying integrated care systems are coming, and it may be that moment where KPAs, as local as you are, understanding the local needs of your kidney care provider and where you live, are finally able to make a real impact. National charities are not going to be able to drive this in the same way. It feels really important that the KPAs, we engage with the KPAs, we ask you to become representative of people living with kidney disease in all of our ICSs. I'm now going to hand over to Ahmed, who will describe the program in the round.
Thank you, Neil. Kirat, I appreciate your hands up. Did you want to ask a brief question, or is it what I wanted to propose is this, that we take questions at the end?
Let's take them at the end, Ahmed. Let's take them at the end. Thank
you. Hi, everyone. So I head the Renal Services Transformation Program at NHS England and Improvement. And I will just be briefing you in terms of what's been happening around the program and what's coming next. So the program as a whole, the aim is to create conditions that will enable the future commissioners, i.e. the ICSs, who will be delegated the commissioning responsibility currently expected to be handed over to them in April 2023. Whilst NHSE and I will still be held accountable for making sure that safe care is being delivered. And that's been worked out, as Neil has referred to a bill, which is a paper which is currently in the Parliament and is anticipated to be formalised as a bill yet to be done. But what that will primarily see is that integrated care systems will be working more closely, making decisions which are more relevant to their local patient populations to devise care services while working with the providers. So the Rstp primarily comes in to support them with this transition and making sure that we continue to provide best possible care to kidney patients across England. I will talk about the approach afterwards, but I really wanted to focus first on the impact that we are envisaging it will have on patients and service users. So if you look at the the honeycomb on the right-hand side of the screen and the center bit, which talks about developing, commissioning, policies that support the whole patient and whole care pathway, rather than it being defragmented and patients going to, as Neil has referred to, for example, to 7 different areas whilst being within the same city, which is quite a challenge. And nationally, I appreciate that there can be much more variation than that in terms of gaining access to services. So having that whole care, whole person pathway is a key thing. We are then working towards making recommendations where it's clinically considered to be safe to provide care closer to home, so it's convenient for patients. Equity of access of services, better experience throughout the care pathway, and then ideally, where possible, reducing waiting times as well by providing care closer to home and having other innovative processes in place which can help with reducing the waiting times that are usually faced throughout NHS services. And then 2 other key bits, which are around smooth transitioning, especially for patients who are transitioning from peds into adult care. And lastly, providing better quality of care where the focus is moved away from spending too much time and resources and money in terms of treating and ideally preventing the spread of the disease or like early identification. And this is where the program is looking at opportunities in terms of how can we possibly identify care sooner whilst working with primary care, within primary care setting as well, so that it can be treated sooner rather than spending that time and resource at a later stage in terms of treating. So those are the possible those are the aspirations that we have in terms of the impact that Rstp outcomes will be having on patients. How are we trying to get there? So that's where the approach comes in. We are engaging with key stakeholders, which I will talk about on next slide as we start designing the content of the program and start to evolve the guidance that comes out from it. And this is where I'm pleased to say that we have got very good representation from National Kidney Federation at the program board, and more importantly, also within the workstream meetings that we have established. And then in addition to that, we have got regular catch-ups with patient representatives facilitated through NKF, where we have got the opportunity to unpick any bits that are not being covered elsewhere. We have then established clinical networks, which sits within all the regions, and they are primarily going to be carrying forward the guidance and the outcomes that will come out from the Rstp program and start implementing it as the program concludes in April 2023. And again, they are involved in terms of helping us with designing and facilitating conversations and influencing the outcomes from the program. The third bit is then data insights and making sure that valuable data that is collected is made available to providers and integrated care systems in future, so that it can be useful to support decision making effectively, rather than it just being collected and not looked at a desirable sort of a frequency. So this is where one of the outcomes from the program is going to be a renal dashboard on which we are working with our partners, UK Renal Registry, in terms of developing it to provide that insight to decision makers. This will then lead into classic quality improvement approach, where we will be encouraging regions as well as clinical networks to start identifying programs and small projects that can actually help them with driving improvement to address issues which are really relevant to their local populations. it's all the purpose eventually is developing a learning system which constantly thrives even when the program comes to an end. But building up that culture, providing those principles which can then be carried forward by local systems to drive improvements further. And this is where we are, like, you know, building in recommendations, which will be, some of which will be low-hanging fruits, easier to address, but then the other bits are something which are going to be transformational and we recognize will take some time to be embedded, but it's really important for the program to recognize those. All in all, the program is driven by clinical excellence. This is where we are. The program is clinically led. We are working with some really brilliant minds across the country and making sure that we are engaging with all the key stakeholders who can actually drive, and we build up on their previous knowledge and experience of incorporating the change. And I will talk about that later onwards in my slides. If we can move to the next slide, please, Pete. So just a journal structure in terms of how the program is structured. So on the left-hand side where it says design and delivery, that's where we have got 5 work streams established. Systems working is looking at cross-cutting themes like reducing health inequalities, enabling better care, supportive care to patients who experience long-term kidney disease, and how do we look after their physical and mental health on top of the pathway that they have to follow. And then also making the best use of data that is available. We have then got 4 clinical work streams which are looking at the pathway and identifying possible best practices which can help us with driving improvements. So these are listed on the screen. I won't talk through them, but Nitin will shortly be giving you a brief overview of what's happening in AKI, just so that you have an idea in terms of what's happening within these work streams. It's worth mentioning over here that this is where we have got good representation from NKF members who are actually part of the monthly workstream meetings that happens around the 4 clinical work streams that I have mentioned. In terms of implementation and design, this is where we are working with the clinical networks, with NHS-CNI's regional teams, and also integrated care systems as they are emerging throughout, to design and to test some of our emerging thinking and move things forward. And then in terms of outcomes, there are 3 bits which the program is working towards. So as I have mentioned, there will be a renal dashboard that will be released along with a toolkit which will be identifying best practices and principles that can help with driving improvements further. And then we are also working closely with NHS-CNI's relevant body, that is the clinical reference group, which reviews and drafts service specifications that are used by renal centers to devise how do they provide care. So that's where the program will be making recommendations in terms of how the service specifications needs to be reviewed and updated. At the bottom of the screen, you will see 2 purple ribbons, and this is where I have listed down some of our key partners whom we are working with. And then I've also listed GERF recommendations and these 10 high impact changes, which I will talk about briefly later onwards. So Pete, if we can move to the next slide, please. I won't talk through this slide in detail, but I just wanted to put it there for your information. But it primarily outlines some of the key domains that each of the clinical and the systems working work stream is working towards, and identifies the opportunities that we are trying to unpick. If you have got any further comments on this, then I'm more than happy to take them afterwards if further details are required. But I just thought that will give you a journal flavor in terms of what's happening within each of the work streams. This is where I would like to invite Dr. Nitin call to talk briefly about AKI. So Pete, if we can move to the next slide, please. Thank you.
Thank you. So my name is Nitin Kole. I'm one of the kidney doctors in Derby, and I am the National Clinical Advisor for Acute Kidney Injury for the Rstp. We know that acute kidney injury is very common. Actually, the incidence for acute kidney injury can be anywhere between 15 to 20% of all admissions in the hospital. And it's a common challenge in the hospitals. And the issue has been that there has been lack of identification of acute kidney injury, which has led to delay in the diagnosis. And this was well established in the 2009 NCE pod audit, which showed that the care, there was poor identification of AKI, and at the same time, the care what is delivered to these patients was suboptimal. We know that in UK alone, there are 100,000 deaths each year in hospital which are associated with AKI, and 30% of them could have been prevented right from the beginning. And this was the audit which was in NCE pod, but subsequently there has been a recent audit which was completed in 2021 and will be published in the UK Kidney Association this year, which shows that the care hasn't improved significantly. The recent data also suggests that the mortality is very high for over 25% mortality for over 75 years. And that is in hospital mortality, and the 30-day hospital mortality will be higher. We also know that the length of stay for these patients, for the patients who suffer from AKI, is quite high, almost 12 days. Median length of stay is 12 days. We also know that the readmission rate is high. Within the first 12 months, the readmission rate can be anywhere between 15 to 18%. The general information about kidneys is also quite poor. So there was a Ipsos Mori survey which was done as part of Think Kidneys in July 2014, which showed that only 1 in 2 people knew the function of kidney and what kidney does. The other important thing is that 2/3 of acute kidney episodes, they start in the community. And this has been now proven with many data sets and the recent data set from a UK Renal Registry as well. So what is Rstp AKI work plan stands for? It stands for what good care in AKI should look like. And what we want to do going into the ICS prevention is a very important step. As I said, 65% of AKI comes from community. It is very important to prevent acute kidney injury in patients who do not have any kidney issues as such, but they may have many other problems. So we want to reduce the risk and prevent acute kidney injury in primary care. We also want to make sure that primary and secondary care integrate well for care of AKI when the patient is identified to have acute kidney injury, and also after the patient has been discharged after an episode of acute kidney injury. So relevant information is passed on to the primary care so they can manage acute kidney injury patient in their primary care setting. Now we know there is unwarranted variation across the pathway, and we want to make sure that this has been tackled. And hopefully with the digital transformation, what has been planned in the AKI care with regards to sort of risk assessment of patients for acute kidney injury, and that will be implemented across all the primary care system and will help to reduce the unwarranted variation. And data becomes extremely important. National Patient Safety Alert mandated all hospitals to provide data with regards to acute kidney injury, the incidence, the length of stay, the mortality. So it becomes, it sets a benchmark and can be used as a KPI for each center. And this data will then drive further quality improvement progress, both in secondary care and the ICSs as well. So there is a lot happening in the acute kidney injury work plan, and I'm more than happy to take questions. We have an NKF representative and that has been extremely, extremely useful. So I will stop there and we'll proceed to the next slide.
Thank you very much, Nitin. And apologies, I've just been conscious of time, and I think I took a lot more time than I anticipated, so I'll keep it brief. But what you see on this slide is 10 high impact changes which were identified last year in June when the program was relaunched after a pause because of the ongoing pandemic. And this is where we had engagement with clinical and non-clinical colleagues, as well as patient representatives, to identify the key bits that we aspire the program to address. And that's what's been listed in the table on the left-hand side of the screen. And then you see how it maps to various work streams that we are working on as part of the program. On the right-hand side, you will see renal medicine GIRF report and a mapping to that, which again identifies that how we are working towards addressing some of the bits and recommendations that came out from the GIRF report, which has been published last year as well. If we move on to the next slide, please. So in terms of what to expect in 2023, as the landscape is still emerging in terms of future commissioning arrangements throughout NHS, we are expecting that there will be an updated service specification released for renal service, specialized services, under the leadership of the Renal National Clinical Director. As I've already mentioned, clinical networks have been established and they will be driving quality improvement further. And then we will be having a toolkit and renal dashboard outlined, which will identify quality and patient metrics to support decision-making going forward. If we move on to the next slide, I just have got our email address over here. As I've mentioned, we do have got regular linkages into NKF. But if you would like to know more about the program or if you've got further queries, then please do get in touch by emailing. And yeah, that's all. We're open to questions and comments.
Well, thank you, all three of you, very much indeed. Very, very interesting. I noticed Kirit has got a question. Kirit?
Thank you, Jim. I think, can I first thank Neil, Ahmed, and Nitin for excellent presentations, really helpful. And we really welcome the ambition, yes, to transform the renal services. And it's right that the word transform is up front there. And as you said, we're working closely with you, and we'd like to work more closely, particularly picking up Neil's point about through the ICSs, yes, as they get established and so on. So we're really looking forward to that. A concern I do want to share, and then that's partly through experience of work we've been doing on home dialysis, is that at a local level, and I'm talking about my hospital, yes, which is that's in Stevenage in the Lister Hospital, where we've been talking about how we increase home dialysis. Yes, that's obviously a big issue for us. And what we're finding really, and I think this is probably a national issue, is that staff in our renal departments are under huge pressure at the moment, yes, for a variety of reasons. But there are also significant staff shortages, yes, there are vacancies in renal departments and everywhere else. So my point is that the challenging agenda we've got to transform the renal services, yeah, needs to be matched with a very supportive approach to local hospitals, yes. And I think I don't see enough of that. And an example of that is home dialysis. So I was just wondering whether we could also think about how we can offer more support. Some of it may be financial, some may be other, to local hospitals to address the challenges we've identified.
Kiran, that's a very valid point, and it's something which impacts all services as a whole. And I appreciate, the point that you have made whilst picking up on home dialysis example. There are bits like, which have been working, looked into at a national level in terms of how that can be possibly addressed. And I think Rstp will be another vehicle for getting that message across in terms of identifying the need. And this is where the whole concept of what Neil referred to earlier is that the change in commissioning arrangements is being brought in for this reason, so that the services gets reinvested, the amount gets reinvested within the service rather than it's being taken away elsewhere. So a very valid point. That's something that we can definitely work towards as we progress with our work. Nitin, did you want to add in something? You're on mute.
I completely resonate with what Kirit is saying with regards to increasing home therapies. And I'm facing that problem now, Kirit, of expanding home therapies in Derby, for example, which has always been well known for home therapies. And I think NKF is such a powerful organization. And why does NHS exist? We exist to serve patients. And that is the crux of the situation, which the hospital management has to understand, that we are here to serve people, and to provide inequity of care or poor care or not giving patient choices is a problem. But as a medic, sometimes it becomes very difficult for me to put that forward, though I'm maybe the clinical director. It becomes very difficult to put that point across the managers because they control the funding. And this is where NKF or patient representative can come into play, that you can demand, you can say, why is this happening? Why is this happening to patient population? Because you are the people who have to bear the consequences of what happens. And I last week, I must have taken 3-4 sumatriptan for migraine, because it has been giving me headache for last 1 week. That how have we reached a situation where we can't increase home therapies, or we can't give choices to patients? And I just thought that we do need patient representative or NKF to question the management sometime to see, what are you doing? What is happening?
Thank you, Nitin. I think everybody agrees with that. And I'm sorry we've overrun time slightly. It's so interesting and so well presented to all of us. I'd like to thank you, all three of you again. I know Neil's gone now. And we look forward to the future being involved with you. Thank you very much indeed for your speeches today. Yes, I agree with you, David. That's really good. Thank you very much.
Thank you very much for having us over here, Jim and Andre. We have got a conversation coming up. So if there's anything that's been discussed later today that you would like to discuss with Neil and myself, then we can pick it up at that upcoming catch up. This is where Nitin and I will be signing off, and thank you very much for your time, everyone.
Thank you.
Thank you.
With our day, and introduce Kirit, our President, and Stephen from the helpline. I'm giving you an update on the home dialysis peer support service. So over to Kirit and Stephen.
I think Stephen is going to start. Over to you, Stephen.
Yep, I hope everybody can hear me.
Yeah.
Yep.
Because I have not slept thinking about people not being able to hear me. Right, I'm going to talk about 10 to 15 minutes about our peer support service, and I'm going to hand over to Kirit for the second part of it. At the end, we'll, if there's time, we'll just take a few questions. So I'm going to share a screen with you of a slideshow that I've put together to explain about our peer support service. So I'm just going to start sharing it now. I hope everybody can see that.
Yeah.
Great stuff. Right, so the NKF KPA support service, this is the update, what I'm going to do, and then say after 15 minutes, 10 to 15 minutes, I'll hand over to Kirit. So for anybody who doesn't know me, I'm Stephen Emerson. I work on the helpline and office administrator, and one half of the peer support service, which is also run by Linda as well. Right, so the peer support service on the second slide. This was launched on September the 1st, 2021. So we all did a lot of training, or trained professionally to be able to set this up, and we all gathered our wonderful peer supporters who joined our team and went through all the training, and by September the 1st we were all ready to up and run. So that's when the peer support service launched. So we're into about September, we're about 7 or 8 months of it now. So right, about the peer support service. Right. The free service is aimed to support people who would like to talk to somebody regarding the options of dialysis at home, or it may be a patient who started home dialysis and would like some further support. Patients can be matched with a peer supporter who have experienced home dialysis themselves or a carer of someone on dialysis. So this can be, just a patient on their own or maybe living on their own, or it could be a couple or, somebody living in the house who wants to care for somebody who's doing either peritoneal or home hemodialysis. So the service, as it says above, the service is free. So if we move on. Right, currently at the moment, we have got 22 fully trained peer supporters who are added to our system, where we can refer patients to when they contact the helpline wishing to know more about their home dialysis options. So on the profiles we've got, this covers a few range of topics. So we've got people on there who have experience with home dialysis. We've got people on there who have experience with peritoneal dialysis, and we've got people on there who are experiencing holidaying with HD or peritoneal dialysis. We've got people on our service who are got experience in caring for someone on home dialysis, and we've also got a few people who are on there who can talk about people how they balance their work around their home dialysis. So a wide range of topics there, profiles there of what can more or less cover everything that we put together. Right. So just moving on. So the contact point for the peer support service is direct to the helpline. So we've sent a various amount of posters and flyers and promotions out, as well as there's a section on the website promoting our helpline service. So the helpline is the main point, so people can call the 0800 169 0936 number, and we can deal with their inquiry. So we take the referral, and then the helpline is in charge of connecting them with a peer supporter they need, which we think is most suitable to the referral's home dialysis needs. So the first point of call, as I said, is through the helpline. So we've got our little referral sheets here ready to go. So when a patient rings up, we can take their details down, and then we'll go look at the profiles and we will match them with the peer supporter that we think was most suitable for them. The helpline is also responsible for updates after a peer support session has taken place. So this will involve contacting both the patient who's had some peer support and the peer supporter, and to get some feedback from them how the session went. Sometimes there may be a follow-on. Somebody may want to talk to somebody again. We will try and pair them up with the same person they've spoken to. And again, the helpline will follow up if it's one discussion, 2, 3, 4, 5, or how many. So in line with the peer support service, the helpline and the subcommittee created a leaflet in October 2021, which was called a COVID-19 perspective on home dialysis. This explains about the advantages and disadvantages of home dialysis, and it was sent out to you know, to try and encourage more people to take up the option of doing home dialysis. We had quite a demand for these leaflets with various units and satellite units asking for copies of these, which they could hand out to their patients. So just after the leaflet was launched, we released, you know, we sent out 2,000 of these leaflets to various hospitals. So that proved a quite popular leaflet within the units. Right, there's been a lot of promotion, what we've done for the peer support. As I said previously, we've sent various laminated posters out to units, to patients, you know, and our volunteers have been very good at helping us promote it. So they've provided us with some pictures, they've given us some quotes, which we promoted on our website, social media, In Touch, Kidney Life magazine, etc. So they're absolutely really good volunteers. We just go to them and they're always very happy to help us with some promotion to promote our service. So there's just a few samples on there, what we've used over the last few months, what the patients have put together themselves to explain the benefits of, you know, of them doing home dialysis and also caring for somebody on home dialysis. So where we stand at the moment with our peer support, the service has so far helped 31 patients. So since the launch in September the 1st. This includes 28 patients we've given out peer support to, and also 3 carers of people who are going to be caring for somebody on home dialysis. So the breakdown of this is we've helped 20 patients needing peer support for peritoneal dialysis. We've had 8 patients needing peer support for home hemodialysis. And we've also given peer support out to 3 carers of patients who will be doing home dialysis. Out of those 31, I'm pleased to say that from the feedback we've been given and peer supporters and patients contacting us back, 4 patients have gone on to actually start peritoneal dialysis, and they're up and running and balancing their life and doing their work and you know, managing their peer support. It's you know, they've been very grateful for the peer support service help that they've been given. We've also had 2 patients since September the 1st who have gone on to start home hemodialysis as well. Right, so as well as the helpline taking the referrals and helping promote the peer support service, the helpline is also able now to give out training to new peer support people who we you know, can add to our, you know, many list of profiles on our database. So the helpline has successfully trained 6 new peer supporters to join our team, which is, you know, done in-house by myself. But just on that, if anybody, we are looking for more peritoneal peer supporters. So if anybody would like to join as a peritoneal peer supporter, please get in touch with the helpline. Right, just before I hand over to Kirit for his section, if there's time allowed at the end, you know, we're able to take a couple of questions. If anybody wants to ask any questions about the peer service, or if anybody wants any information about the peer service out of the KPA day, please feel free to contact the NKF helpline and we'll be glad to help you. You may be able to help with promotion, putting posters up in your units or flyers, or talking about our service in your KPA meetings.
Okay,
so
thank you.
It's over to Kirit.
Thank you very much, it's Stephen, for the excellent presentation. And can I just say congratulations to you, the helpline, and I know lots of people within the NKF who have worked, and to launch a new service is never easy, but we've obviously done we've done that, you know, with great success, and let's build on that. What I'm going to talk about is really an update on our home dialysis campaign, which you will all know about. So if you look at the second slide, Pete. So quick background, you recall that the first report we published was in January 2021. And again, hard copies of these reports have been sent to all chairs of KPAs. So I hope you've got them. And then we recently published the 1 year on report saying what's happened in a year's time. And again, sure you'd have a chance to look at that report, but overall, we're disappointed with the progress we made over the year, because we've used the latest data which the UK Renal Registry provides, and the latest data nationally is available for 2020. So it's always a couple of years behind. So that's the latest available data. And we think that one of the main reasons why the progress has been disappointing is the impact of COVID. And we all know how that's devastated services, not just in renal departments, but within the NHS. But what is positive is that there is a great deal of support from the kidney community. I don't mean just patients, but when you talk to nurses and to clinical directors and nephrologists, everybody now agrees that we need to do more to increase home dialysis. And this target, which has been around for a little while, I think is broadly accepted. So now when we say this is the target, nobody says, oh, why is it 20% or it's too much or whatever. People recognize that that's where we need to get to. So at least 20% home dialysis patients in every center. So if you look at the next slide, I'm just going to share some broad data. So the first thing is, if you look at the figures overall, so these are percentages of patients who are dialyzing and how many of them dialyze at home. So 5% dialyze nationally on home hemodialysis, 13% on PD, so a total of 18%. But as you see from the pie chart, the figures are across the 4 nations are very different. Wales and England are doing much better, and whilst Northern Ireland and in Scotland, clearly there's a lot more work to be done. And then when you look at the centers, there's 70 centers nationally who provide home dialysis, and 49 of them have less than 20%. So to get to 20%, there's a long way to go. And then in the report which we've sent you, if you look at the data there, and we've also got center by center data. So those of you who look at the report, the hard copy. So it's on page 9 of that report. There are 20 centers which are not doing well. Yes, by not doing well, I mean that they're significantly below the average, and 13 centers are doing well, which means that they're doing much better than the average. And the range is enormous. So just to give you an example, this is from page 9 of that report. If you take Derby, and Nitin Kohli was there from Derby, yes, talking about the issues earlier, there are over 35% of their patients who are on home dialysis, 35%. Whilst on the other side, I'm just picking one out at random. If you take Bradford, they're 10% on. So the range between around 10% to over 35% and so on. So there are huge variations, yeah. And then if you look at the next slide, we also know that ethnicity and social class are also factors here. We have shared some data on ethnicity. We've just received data on social class, so we didn't have time to publish it. We will publish it. But broadly, what this is saying is that if you are from white background, your chances of getting on home dialysis are much greater. If you're from Asia, so 19%, 16% for Asian, and 14% for Black. And even when you look at the two pie charts on the right-hand side, are those which are centers which have large number of patients from ethnic minority background. Even there you see the differences between. So this is again a big issue which I don't think is at enough attention. So we're again highlighting the inequality which was referred to in the Neil's presentation, the Renal Services Transformation Program. Equality is one of the main themes within that. And then if you look at the next slide, Pete. So obviously you've seen the first year report. Our campaign continues. So what are we doing at present? We obviously written back to the 4 governments, highlighting the figures and asking for their responses. The all-party parliamentary kidney group, we're hoping to meet now in the summer, so we will be raising it with them. And the Renal Services Transformation Program, which you heard about, obviously we are working with them, particularly the dialysis work stream, on how they can support us in increasing home dialysis. So that's at a national level. At a local level, we've written to the clinical directors of renal services, sharing the report, and again, asking for their responses. And obviously, most importantly, we've written to all of you as KPA chairs to, again, seek your support in moving things forward. And also at a national conference, the UK Kidney Week, this is a national conference, well attended in June. We're having an NKF session on home dialysis. We move to the next slide. So how can KPAs help? So the first thing I would say is, if you've not done so already, look at your center's data. Yeah, the 2020 data which we've sent you. See where you are. Ask your clinical director to come and talk at a KPA meeting. I know many KPA meetings are virtual, saying, what do you think about this? How can we move things forward? Offer the support of the KPA, and I'll talk a little bit more about how I think the KPA can help. And any interesting things happening locally within your area, share it with the NKF, because we want to spread good practice on this, yes? And we know that good practice happens locally. It doesn't happen nationally, it happens locally in hospitals. Any good ideas you have, let's share them. And as we begin to have regional meetings and so on, let's raise it regionally as well. I know that's not been possible to a great extent at the moment, but things are going to open up, so let's make sure this is on the agenda. Then if you look at the next one, these are some practical things I think we can do locally within our KPAs. So the first thing is picking up what Stephen was saying, let's make sure that the posters, the peer support service posters are in all our areas within our units and so on. And the leaflet which Stephen mentioned, again, it's a new leaflet, and it takes account of the impact of COVID on home dialysis. So I think it's a very important leaflet. Let's make sure that that leaflet is widely circulated and available in all our units. Then you all have newsletter or website, whatever means you have to communicate. Let's have more case studies of somebody locally in your unit who is on PD or on home HD, who are happy to share their experience, So let's promote that locally, because nothing more powerful than having somebody local sharing their experience, saying, this is what worked for me, these are the challenges I had, and so on. But clearly, we need more case studies nationally. And then, again, I know funding is not always easy for KPAs, but how can we support home dialysis patients and carers locally? If we can provide, we used to have education days. Many of us used to have education days where they went away for half a day or whatever. Can we provide some funding for that? Or can we provide some funding from the KPA for social events for dialysis patients? So these are all things, some of the things I thought of which we can do locally to support it, because I think there is still quite a lot of evidence that many patients do not know enough about home dialysis, or if they know, it's not been explained properly, or sometimes it's not explained in time. You know, they mostly they go on in-center dialysis and they get used to it, and then they don't want to change. So my last slide, Pete, is this is very much a team effort. Yes, so within the NKF, this is one of our high priorities. We're going to continue the campaign. And again, you've got the report. And I'm delighted that we've got a team of 14 staff and executive members who are leading on this campaign. And it's really most grateful to Brian Child, our vice chair, who is leading this particular campaign and chairing that group. So that group is working really well. But in the end, I want to just say, it's not just what we do nationally, what we do locally as well is equally important. So we need everyone's support. And I'm always optimistic about these things. I think we will make a difference with everyone's support. So Pete, Jim, I'm going to stop there. And if we have time, then I'm sure Stephen and I would be happy to take questions.
Thank you very much, Stephen, and you, Kirit. Has anybody got a question for Kirit or Stephen?
Yes, Jim, it's Richard from Southeast KPA. I just actually put a question on the chat, but I'll ask it now. I'm, by the way, a patient doing home hemo. I've just joined as a patient member a collaboration that's been set up by the UK Kidney Association in the Southeast. This initiative is between 5 centres, and it's in order to develop home therapies amongst those 5 centres. Do we know in your study how many of the centres, of the 70 centres you mentioned, how many of those have joined such a collaboration that's been set up by UK Kidney Association? Because the one I've just joined, which has just been set up, seems to have a purpose about it, and it seems a good vehicle. So I wonder what you know about it.
Yeah, no, thank you, Richard, for sharing that. I didn't know about that. What we do have, though, is the 2 things I'll say, and I'll come back to your specific thing. In our report, we have talked about how centers can collaborate. Yes. And there is it's a very awkward acronym. It's called KQIP. Yes.
Yep. So
this is, you might have heard about that.
That's the same initiative that I've. Is it the joined.
Same initiative? Okay. So through KQIP, work is going on, and we want to increase our partnership working with KQIP, and it's in our report as well. Yes. On page 17, we've set out the work of the KQIP. But we would be very interested, perhaps after this meeting, Richard, you could drop us a note to see exactly what's happening there. And we would very much want to support collaboration. Yeah, and it picks up David Coyle's point earlier, you know, regional collaboration. Yes. So we want to be involved in this and support it, because I think some of these issues, as I said, if people can learn from each other, and we would want to support that. So I'm really pleased, Richard, that you're involved in it, but perhaps you could share that with us so we can share that widely.
I will do that, Kirit. It is a very patchy story. Of the 5 centres, you talked about the 20%. None of them were achieving 20% now. Right. One was very close to that, but some were way
back. Absolutely.
And it seemed to be a function of the resources that they had available to them seemed to be the critical thing. But I'll drop you an email, distribute it, and tell you what my experience is so far.
That'd be really helpful. Thank you very much, Richard.
Thank you, Richard. Would be helpful. Does anybody else got a question? Yes. Well, Peter.
You got me? Yes. I was just going to ask whether, I think we've covered more or less on the last point, as to whether the shortages of staff and the difficulties are producing some sort of rationing of people going on home hemo. I've been on it for 8 years, and it's transformative completely.
I think, Peter, I'll try and answer that. I think it's not a full answer, but it was interesting the comment Nitin Kohli from Derby mentioned, right? I mean, he is the best performing, that's the best performing center in the country, right?
Yeah.
On home dialysis. And he was expressing concern about staffing, yes? It's saying, how do I maintain this and so on? So I think this is just anecdotal, but my experience is that, you know, in every center, yes, somebody has got to decide on priorities, yes?
Yeah.
And on staffing. So how much staffing do you put on home therapies, PD and home hemodialysis?
Yeah.
How much do you put on other things and so on? Firstly, it's a local decision, yes? The clinical director will make that decision. And the clinical director will also need to make a case to the trust, yes? To the senior management, yes?
Yeah.
To get more funding. And that's what Nitin was saying. But my gut feeling is that in many centers, not enough staffing is allocated to home dialysis, yes? And that's why we're getting the, you know, so many centers below the 20%.
Yeah.
So one of the things we can do as kidney patients and KPAs is to help raise this within the trust, yes, to say this is a priority. And when a senior clinical director says he could do with help from the NKF and from patients, I think we should think more about how we can do that. We are in fact communicating not just with the clinical directors, but also with the chief executives of trusts. But I think it's something I think we should all think about, saying how can we support in adding our voice, yes, to getting this prioritized in terms of funding.
Yeah, thank you, Karen.
Thank you both. Just locally, there's a problem with the staff, and also we've got a problem locally with vascular access, and all those things are preventing people from transitioning to home therapies. So it's not just, you know, the trust doesn't want to make more. There's things blocking certain ways that they can send people home. It's frustrating that we've got 40% of our patients in our area are on perm caths because they can't get a fistula fitted, and that's, you know, it's just a preventative of the moving forward on this subject. Just to put in a different reason why perhaps different centres are a bit slower and various problems. But thank you both, Kirit and Peter. Yes.
Can I just ask a question?
Yeah, quickly, Sharon.
Yeah, Kirit, has there been any data to look at how many patients are wanting to go home? Is it a catch-22? If people aren't wanting to go home, then clinical directors aren't putting in the staff and aren't putting in the money because there isn't the demand. Because it's a mindset, isn't it? We're putting case studies in our next magazine to try and promote it. But if people haven't got the mindset that they want to go home, then are the clinical directors going to put the money in and put the staff in if people aren't asking to go home? What's the data on people wanting to go home?
I think, Sharon, that's a very important point. And the data we have in the report, you know, the 1 year on report on page 15, we've shared some data on surveys. So there's one survey which was done by Quanta, and they found that 34% of patients haven't been offered home hemodialysis by their unit. Yeah. Now, that's one part. The other could be that there are patients who don't want to be on home dialysis, and that's perfectly understood. Nobody's saying everybody should be on home dialysis. When we're talking about 20%, yes. So I think there's an issue about, are patients getting information about home dialysis at the right time Yes, that's the first thing, right at the beginning when they're considering options. Yes, that's the first thing.
Yeah.
And the evidence is that not all of them are. And the other bit is that where people have concerns about home dialysis, how can we give them accurate information? And this is where our peer support service comes in. There's nothing more powerful than talking to somebody who's actually going through that or has real experience of that. So I think there's work to be done here, both I think locally, obviously, by the centers, and to some extent, Sharon, it also depends on the person who is having that conversation. Yeah, the nurse, usually it's a nurse, isn't it? Yes, yeah. How they express it. Some nurses will not promote home hemodialysis for a variety of reasons, and their personal views will come in. So the question is, to what extent are we giving accurate information so that patients can make informed decisions? If they don't want to dialyze at home, that's perfectly okay, and that's their right, yes. But they should have the option of considering home dialysis.
Okay, thank you. I think we need to move on. We're already overrun.
I want to ask one question. Yeah.
Okay. Well,
Kerry.
Yeah.
I had some patients who want to do home dialysis, HD dialysis at home, but they are in a rented accommodation. So I don't think the landlord will allow any alteration to their building. So how do we go about it?
Yeah, not an easy issue, I think, and I don't know the answer to that, Nick, to be honest. Yeah, but what I would say is that one of the issues is about how much space do you need to dialyze at home, whether you rent it or it's your own property. And it's interesting that some units, it depends on the amount of space you need, depends on how frequently the supplies come in, all the fluids and everything else, how much space you need. And some units have weekly supplies, so you don't need too much space. Some will have monthly supplies and so on. So I don't know the answer to the rented thing, but I think one of the issues is, can we make sure that the need for space to store fluids and other materials for home dialysis are kept to the minimum? Yes, if you see what I mean. It just partially answers the question. It's not a full answer.
Yeah, I know. Because we have an ongoing situation with one particular patient. The space is small, and I don't know whether NKF can work with the councils so those in private accommodation can be given or afforded a council place where they will take into account all these things.
Nick, can I suggest you send Andrea and me an email, and we'll see what we can do.
Okay.
Yeah.
Will do.
Charlene, I'll give you a couple of minutes quickly because you haven't spoken yet. And then we must move on. I'm afraid, sorry, we could be here all afternoon. It's such an emotive.
I understand that, Jim. I was just going to bring up, I know that for a fact in our area, we don't have, I don't know how many patients we have on peritoneal dialysis, but I know at the moment we do not have any home hemodialysis. When I was on dialysis, I was looking at going home dialysis, but I know that it's not actually promoted these days due to, in our unit, due to funding. So they don't even discuss it with the patients. And I know that there are many patients who would rather not go home, but then there are younger patients who would probably go home. But with space isn't the issue with hemo, it's to do with having to have water units put in so that they're able to dialyze and have a dialysis machine at home for hemodialysis. We're having trouble getting a meeting with our unit. They don't include us in a lot. We're being quite forceful, but they're still being quite resistant. But it does interest me about how many patients would benefit from home dialysis. Yeah, it's not really looked at in our area.
Okay, where are you, Charlene?
We're in, sorry, Plymouth. We're in Plymouth, which is,
Plymouth.
yeah, it covers Plymouth and North Cornwall, South Devon and North Cornwall.
That's interesting, Charlene. I'm just looking at the Plymouth figures for 2020. You have 0% on home hemodialysis and 17.7% on PD in 2020.
That would be about right.
That's about right, Charlene, isn't it? So I think there's an issue there. And perhaps, Charlene, outside this meeting, perhaps you could send us, and let's see if we can do something together to move that forward.
That's lovely. Thanks,